Welcome. My name is Susan Voss, and I'm a clinical associate professor at the University of Iowa College of Pharmacy. This video is intended to give you a brief overview of what we discussed at the 2018 Faculty Development Workshop at All-Ain University. This topic is why is experiential learning critical to contemporary pharmacy education? So what I hope to do in this session is to provide you with some insight into why experiential education is critical in a contemporary pharmacy curriculum. So I want you to think about first, how are we teaching students? So right now, a majority of the way we teach students happens in the classroom, happens in a lab activity, and I want to highlight some research that had been done in Maine at the National Training Laboratories, looking at how much information we retain when we're being taught as students. And so this learning pyramid charts the average retention rates for various learning methods, methods of teaching. These represent the results from research published by the National Training Laboratories. So if you look at this pyramid, the top is 5% lecture. So about 5% of information is obtained when we hear lectures, which kind of makes sense because it's a very passive style of learning. Versus if you look at the bottom of the pyramid, when you teach someone else how to do something, you retain about 90% of that information. And so you can see reading, audiovisual, and demonstration really are at the top of the pyramid, and those are styles that we like to use in the classroom and when we're teaching, but really provide the least amount of information or knowledge retention. So you can see on this pyramid, the top part of the pyramid are really our passive learning techniques, but the bottom of the pyramid are our active learning techniques. So you retain 50% of information when you discuss something as a group. If you practice doing something, you retain 75% of that information. And so what we really want to do is try to teach our learners using active methods. So this data really shows the importance of experience-based learning when it comes to teaching students. So again, as I said earlier, classroom is what we see at the top of the lecture pyramid. Toward the middle of the pyramid, those are maybe some of our laboratory activities or small group discussions. But then at the bottom of the pyramid, where you really get a lot of information retained, is in what you see in our experiential curriculum. I want to highlight another model that really exhibits why experiential learning is so critical to today's pharmacy student learner. This is research published in the 1970s. It was came out of Harvard University in Boston. It's really the Perry model. Perry is who conducted this qualitative research from the 1950s. And he basically asked college students, what stands out for you over the last year? And he tried to highlight the forms of intellectual and ethical development during the college years. So he basically brought it down into three categories. So the first category of learning was dualism. So this is where a student thinks that everything's solvable. There's always a right answer, always a wrong answer. Students try to learn and memorize the right answer. The second model was really multiplicity. This is where students start to realize that there are some things that we know and there are some things that we don't know yet. And they try to learn how to find that information. Students start to recognize that really there's more than one answer to the question, and they start learning the exceptions to the rules. The last category that was highlighted in Perry's work is relativism. And this is when students start to recognize that yes, there is more than one answer to a question, but often some answers are better than other answers. So learners start to evaluate answers. So if you think about it in the context of a patient, if you're presented with a patient problem, there might be a lot of ways to solve that through various medications or different treatment plans. And you want your students to start to evaluate which answer is correct. This is where the student starts to take responsibility or makes a commitment for their decision that they're making. And they learn that students learn that this commitment is sort of ongoing, unfolding, evolving activity. And this is definitely very important as you think about patient care. So if you think at the top of this chart, dualism really is when the teacher is the authority. The teacher knows everything. The teacher knows the right answer. The teacher is the authority. But toward the bottom of this slide in relativism, really you get to where the teacher is a resource. And that's really where we want to push our learners in experiential education, where they're doing a lot of the learning and the teacher or the preceptor becomes a resource to them rather than an authority figure. So in this model, at the top of the slide, you see that dualism, the student is really a passive receptacle for knowledge. That's what happens often in the classroom, where the student's just listening to a lecture. They're trying to just retain and memorize as much as they can. Versus in relativism, you have a student who is an active agent in defining arguments and solving problems. And so we want to get the student to those more complex forms of learning, intertwining cognitive and affective perspectives. That's really the heart of a college education. That's really the heart of healthcare learning. And so we want to push students to the relativism phase of learning. The other framework I want to point out as we're thinking about why experiential education is so important is I want to talk about Miller's pyramid. Miller's pyramid is really a pyramid that was created that highlights the assessment of clinical skills and clinical performance. And so here at the bottom of the pyramid, we have the knowledge, or does the student know the information we're trying to teach them? The next level on the pyramid is, does the student know how to do something? So they have the understanding of how something is performed, how a clinical skill is performed. They know how to take a blood pressure. The next area up on the pyramid is shows how. So this is where the student actually shows you that they know how to perform a clinical skill, such as take a blood pressure or take a medication history from a patient. And then the top of the pyramid is really when the student actually does the activity. They do it either in a simulation center or as a live event for learning. And so all these frameworks really highlight how critical it is that we are utilizing experiential education when we're teaching our students to become pharmacists. And so when we think about putting together a pharmacy curriculum, you have classroom components, you have simulation components, and you have experiential components. And we hope that we put all that in a bucket and the student's going to be ready for practice. But there are a couple questions we have to ask ourselves. So we want to say, well, what's the correct mix? How much experiential education? How is it aligned with the curriculum? And so we want to ask ourselves, how much experiential and when? So it's really important when you're thinking about when do you offer experiential learning opportunities for your students. You want to think about aligning it with didactic curriculum, aligning it with simulation so that they're learning concepts in the classroom and then they're able to go out and apply that to a real patient. So for example, you want to teach the basics of, how to provide patient counseling and education to a patient about their medications. Then maybe you want to have that activity done in a lab where that's simulated with a classmate or a patient actor. And then you want to have the student go out and perform that medication, education, or counseling session with a real patient. It's really important to start experiential learning early in the curriculum and have it continue to build throughout the curriculum, ending with advanced skills, sort of the capstone type experience and those advanced experiences. So one example that we highlighted last spring in the literature was the alignment learning bridge. This was a great example of a publication that was done that aligned early experiences with the pharmaceutical sciences. So they had students identify a medication, they had to review a package insert and answer some questions on that. And then they went and provided patient counseling pearls, thought about with this medication, what would be the top counseling pearls. They reviewed that with a preceptor and then they submitted a written response. And so this was sort of a way to tie in what they were seeing at their practice sites with what they were learning in the curriculum. So if we think back to our funnel and our bucket that we're putting all these types of learning in, the next thing we ask ourselves maybe is how are that we going to know that they're ready for practice? How do we assess their skills when they're out on these practice-based learning experiences? And so if we go back to our Miller's pyramid, you can see that there are lots of different ways we can assess competence. So in the knowledge area, we all know that you can do some factual based assessments, maybe multiple choice questions, an essay, or an oral assignment is a great way to assess the knowledge base of a student. Knowing how to do something, you might also continue to use multiple choice questions, essays, oral assessments, but maybe they're clinical context based. So maybe they are a patient assessment or a clinical case where the student has to answer that clinical case. Continuing up the pyramid, then you have the shows how example. And this is where you might have a performance assessment in vitro or in a lab setting. So we might use a performance-based assessment in a lab with a rubric where a student comes in and they do an example of an activity with a live patient case or a standardized patient actor. And then lastly, the does, and this would be performance assessment in vivo or in real time, in real life. This is our performance where we are having a preceptor assess the student's performance in an IPPE, an introductory or an advanced practice-based experience where we have maybe a standardized rubric or an evaluation that we use for those students when they're out in the community or in the hospital setting doing these activities and showing that they can do these clinical skills. So if we think back to our bucket where we've got all this different learning going on, the last question would be we want to ask ourselves is how do we prepare our students for future practices? So we don't necessarily want to just train them on what a pharmacist is doing today, but we want to think about future practices or future advancements of what it is that students might be doing in the future. And that's really why it's critical to have early exposure to clinical pharmacy. It does a couple of really important things. The first thing it is it really helps students understand the expectation of professional socialization. So it gives students ideas of what is the expectation going to be related to professionalism, related to behaviors and attitudes and values. They'll be able to see and practice this professionalism and get feedback on it early in their curriculum so that the student will eventually evolve into a professional. The other really important reason for early exposure to clinical pharmacy is that students understand the philosophy of patient care. So it's really important for students to learn and see real patients as they learn about diseases. So when I talk to students, I love seeing that light bulb moment when they learn about something in the classroom and then they immediately go to a pharmacy that afternoon and they see a patient with that disease. I mean, that is a really great way to have things connect throughout the curriculum. So it allows them the immediate application of knowledge that they're learning in the classroom rather than learning all this knowledge and then applying it at the very end after a year or a certain amount of time has gone by. So early exposure really helps them understand that philosophy of patient care. The other concept that I think it's important to talk about is the concept of see one, do one, teach one. So C1 is really having students have that early observation, early practice observation where they're able to see a pharmacist providing high-level patient care to their patients so that they can have that vision of what's the end point, where are they supposed to be at the end of their pharmacy curriculum. Then the concept of do one is where the student practices that activity. They practice it in a lab or they practice it at a site where they have a pharmacist watching them, giving them feedback, making sure they understand what it is that they need to do. And then lastly, if you can get to this level, it's fantastic having the students teach someone else how to do something. So that might be where you set up a curriculum where you have peer-to-peer teaching. So maybe you have the senior students teaching the junior students a concept, or teaching them a skill in lab, because that really helps ingrain those topics into the senior students. And then, my goal when I'm having students is I hope that one day they will become a preceptor, because I really think, we have to keep in mind that, as a healthcare provider, we all have to be lifelong learners. And, I really think one of the best things for students to do is later on become a preceptor, become a clinical teacher in pharmacy where they have students at their practice site. So that's kind of my ultimate goal when I'm training students, is hopefully they'll come back and serve as a preceptor for our university. So, in summary, I think it's really important to keep in mind that learning is a process. If you think about the time, I think of it as learning to ride a bicycle. You start with a tricycle, you've got a training wheels on your bike, then maybe you upgrade to take off those training wheels. And then, later in life, maybe you're lucky enough to, ride in a big bike race where you're that experienced expert. But you have to think about where your learner is along that way, and think about, does this learner need the tricycle, or do they need the training wheels, or is it time to take the training wheels off and let the student go and perform things on their own? So thank you for watching this video. Thank you for your interest in experiential education, and I look forward to seeing you at the faculty development workshop in 2019.